After two brilliant lectures and presentations, I am going to say something regarding the echocardiographic approach to mitral regurgitation. Echo diagnosis of mitral regurgitation is often easy, but complete evaluation may not be so. As is the two cases on the left side, this is a case of cardiovascular syndrome, and here you can easily see the mitral regurgitation, most probably of moderate severity. And on the right side, the two echocardiographers missed the diagnosis of mitral regurgitation, and they actually took it as a case of tricuspid regurgitation only. The lady was having recently prosthetic valvular disease. And whenever you are going to evaluate by echocardiography a case of mitral regurgitation, what are the things that are compulsory to be evaluated? The first one is what is the mechanism of mitral regurgitation, and another one is what is the severity of mitral regurgitation, and absolutely there should be what are the consequences of mitral regurgitation on the left ventricle, left atrium, and pulmonary circulation, because these parameters have got much impact on the further evaluation and management of the patient. I will highlight on the first two parts of the three elaborately, because these things are more often neglected in clinical practice in Bangladesh. You know that there is MR, and now you should determine the mechanism of mitral regurgitation. You have certainly heard the two nomenclatures, primary or organic MR, which is actually MR due to mitral valve apparatus, which is due to disease of the left ventricle itself. The valve apparatus is itself not affected. The examples of primary or organic MR are rheumatic MR, degenerative, ischemic, infective endocarditis, and congenital. And in case of secondary or functional MR, the typical example is MR due to ischemic heart disease, and also in case of dilated cardiomyopathy or MR associated with hypertrophic obstructive cardiomyopathy. Rheumatic MR, as you have already known, that concomitant mitral stenosis, and also if there is thickening of the anterior mitral leaflet 3 mm or more, or there is caudal thickening, commissural fusion, restricted mobility of the leaflets, and excessive leaflet tip motion during systole, these features may hallmark the diagnosis of rheumatic MR. And here you are seeing two cases of two clips illustrating the rheumatic MR. Absolutely, there is concomitant presence of mitral stenosis, so the diagnosis is not so tough here. Now I am going to say something regarding degenerative MR. Degenerative MR is a group of disorders in which there may or may not be myxomatous degeneration of the mitral valve. Sometimes there may be some thickening as well as the deposition of calciums on the mitral leaflets and other parts of the mitral valve apparatus, leading to the presence of mitral regurgitation. This is an example of mitral valve prolapse. The classic definition of mitral valve prolapse is that the tip of the leaflets are often just displaced within the interior of the left atrium 2 mm, or somebody tell that this is 3 mm or more, and this should exceed the plane of the mitral valve annulus. And here you are seeing eccentric mitral regurgitation. This is another example of mitral valve prolapse. Here you are seeing the prolapse of posterior mitral leaflet, and this is causing mitral regurgitation. Sometimes we may come across to bileaflet prolapse, as is the case here. Just see that two leaflets of the mitral valve are prolapsed, and as a result of which there is central MR. This is not eccentric MR, because both the leaflets are prolapsed here. And mind it, in case of eccentric MR, the severity may be of apparent less. Another term is flail mitral leaflet, and it can affect both AML as well as the PML. Flail means the tip of the mitral valve leaflet, whether it is AML or PML, is directed towards the interior of the left atrium, as is the case here. and the cause may be rupture of the chorda. And here the MR is usually of severe, very severe type. You are seeing this here, and this is also eccentric MR. This is another example of flail AML. This is a case of papillary muscle rupture secondary to acute myocardial infarction producing severe MR. The mitral valve prolapse sometimes may be secondary. This is not due to, probably due to myxomatous degeneration, as is the case here. This is most probably due to rheumatic heart disease, and this has led to the thickening and shortening of the chorda as well as the thickening of the AML and PML. And here the tip of the PML fulfills the criteria for the diagnosis of mitral valve prolapse, but here the underlying etiology is rheumatic heart disease. Degenerative MR, this is very common in our clinical practice, and you see here the movement of the myocardium is relatively preserved, and here the mitral valve leaflets show degenerative changes as illustrated by the thickening and some sort of calcification, and also there is mitral annular calcification, and just the MR present here may be of mild to moderate severity. This is very common. Sometimes secondary MR actually very difficult to treat. So this needs differentiation from the primary MR. Here, this is another example of secondary MR. This is due to the myocardial infarction affecting the posterior segment of the left ventricle, producing mitral regurgitation. This is a very common cause of mitral regurgitation, that is the ischemic MR. In this case, say there is hypokinesia or virtual akinesia affecting the lateral wall of the left ventricle, and because of this and the teetering effect of the myocardium, ultimately the MR is being produced here. And MR associated with DCM is a very common one, as is illustrated here. This is the case of a long-standing hyperthyroidism that has led to the tachycardia-induced cardiomyopathy, and ultimately ring dilatation has led to the presence of mild to moderate mitral regurgitation. Mitral regurgitation is a very common phenomenon in case of hypertrophic obstructive cardiomyopathy. The main cause may be, the underlying etiology may be due to the presence of systolic anterior motion of the mitral valve apparatus, or sometimes there may be abnormality of the anatomic abnormality of the mitral valve itself. So this needs further evaluation. This is another interesting one that is often under-recognized. In a case of long-standing atrial fibrillation, all the things may be okay, but the only abnormality may be the ring dilatation of the mitral valve due to the dilated left atrium induced by long-standing atrial fibrillation. As is the case here, the LAVI is here 38, and there is MR, which is mild to moderate MR. This is an example of atrial fibrillation induced mitral regurgitation. And sometimes you can get some other rare causes of mitral regurgitation, as is the case here. This is a case of left atrial myxoma, and in presence of left atrial myxoma, there is moderate degree of mitral regurgitation. Certainly, this is eccentric. Sometimes there may be multiple mechanisms playing at the same time, as is the case here. There is akinesia of the wall of the left ventricle, and at the same time, papillary muscle rupture has led to the presence of severe eccentric MR. The next step is to determine the severity of the MR, and this is actually a tough job sometimes. Most often we do qualitative assessment, and the parameters that we often consider is the jet size, vena contracta, and also flow convergence, left ventricular size and function, and certainly other parameters like PA pressure, mitral valve morphology, left atrial sign, and other indirect signs. And the semi-quantitative parameters we often practice is size of the vena contracta, and also the size of the flow convergence zone, and also the jet area. And the quantitative assessment of the severity is a bit tough, but there are two methods available. One is based on the PISA method, and another one is volumetric assessment of the severity of the mitral regurgitation. Simply, there are some clues in case of spectral Doppler imaging of the mitral regurgitation. If the density of the spectral envelope is rather faint, it may represent mild. velocity 5 to 6 centimeter per second, meter per second, this may be also mild. And if the shape is rather symmetrical, this is an example of mild mitral regurgitation. And on the other side, dense presence of dense envelope and also the lower velocity and asymmetrical shape of the envelope may be due to the presence of severe mitral regurgitation. Whenever you are encountering a case of mitral regurgitation with complete just non-cooperation of the leaflet, just see here on the right side, virtually you need not do further assessment for the severity of the MR. This is always accompanied by presence of severe MR. So carefully look on this. The color flow jet can give you much information regarding the jet size, jet configuration, direction of the flow, central or eccentric jet, or wall hugging jet, and sometimes the jet area and LA area ratio. The jet size, the larger the jet, the severer the MR. This is the dictum. And if you will get less than 20%, 20 to 40%, or more than 40% of the left atrial area, this may be mild, moderate, or severe MR. But this is not always very reliable. Jet configuration may be another very important clue. A just eccentric jet is always of moderate to severe mitral regurgitation. This is not virtually due to mild mitral regurgitation. Eccentricity is an important clue. Another one is just sometimes we may be in false position regarding the severity of the MR. We have to look at the systolic function of the left ventricle. If the driving force is not enough, the apparent mild MR may actually be moderate to severe MR, as is the case here. The driving force is here. So this apparent mild mitral regurgitation may actually be mild, moderate, or severe mitral regurgitation. So always look at the left ventricle at the same time, and the circumstantial evidence as illustrated by the presence of the dilated left atrium and also certainly the PASP. You should always look at the left atrium. The only pitfall is that if there is acute MR and not enough time for the compensatory mechanism, the left atrium may be of a normal size in presence of severe MR. I am not going into the assessment of the pulmonary vein for the assessment of severity of MR. The next few words regarding the vena contracta. This should be in everyday practice. A typical jet of mitral regurgitation has got several parts. This is the flow convergence zone, and the narrowest part is the vena contracta, and this is the whole jet area, and the jet length is from here to here. So we have to have some knowledge regarding the size and shape of the mitral regurgitation jet. Vena contracta practice, the vena contracta is the narrowest part as is assessed here. The appropriate setting is very important. The color scale that has been recommended is 50 to 70 centimeter per second. And here the severity that has been advocated is if it is less than 3 millimeter, this is mild. If it is 7 millimeter or more, severe. And the values between 3 and 7 may be of moderate or not. Further assessment is often needed. And quantification of MR severity, this is not tough with the modern machines because the modern machines has got software, and if you are going to put some values, this can give you the volumetric method for assessment of mitral regurgitation as well as the PISA method. I am not going into details of this assessment because of the scarcity of time. I am going to share with you some additional things like there are some pitfalls of the volumetric as well as the PISA assessment of MR. The typical example is the presence of multiple jets in a patient with mitral regurgitation. And in presence of multiple jets, all these parameters or the ways of assessing severity may not be of very accurate one. Sometimes in your lifetime, you can get some cases of mitral regurgitation like the case presented here. This is a case of restrictive cardiomyopathy. This is due to cardiac amyloidosis. You are seeing the hypertrophy of the left ventricle and all the other chambers of the heart as well as the interventricular septum and the valves all are the thickened, and also the speckled or the granular appearance of the myocardium. just look at here, and because of this, the MR is being produced here. So sometimes you can encounter these types of etiology. And this is another etiology you may or may not see in your lifetime. And if you see this is in your lifetime, you may be lucky or unlucky. This is a patient, a middle-aged school teacher who presented with presence of some visual problems and consulted an ophthalmologist who ultimately sent the patient for further evaluation of the sound over the precordium. And whenever we just evaluated the patient further, we certainly got some sorts of bony involvement, as is illustrated by the presence of deforming arthritis of the hands of the patient on the left side. And also, at first, we thought that this may be a case of rheumatic mitral stenosis as well as regurgitation. Look at here, the valves, both the aortic and the mitral valve leaflets and cusps are definitely thickened, and also there is changes affecting the subvalvular apparatus, and there is aortic regurgitation as well as the mitral regurgitation, which may be of mild or at best moderate severity. Whenever we thought of some rare diseases, ultimately further investigations revealed the presence of polysaccharidosis, mucopolysaccharidosis. So my take-home message is that echocardiographic diagnosis of mitral regurgitation is often easy, but complete evaluation may be a difficult task. Every attempt should be made to determine the etiology. Assessment of severity should be based on integration of all the available parameters, and only practice and perseverance can make a difference. Thank you all for patient hearing. Happy New Year.